Hello, Gut Check Project fans and KBMD Health family. Welcome back to the Gut Check Project. Ken, we've been gone just for a little bit.
Yes. So unfortunately, we lost our studio. Our beloved studio that we did the whole episode on the sign, and we put so much into building that studio, and we lost it. So we've been homeless. Eric and I have been homeless for 6 weeks, a month, more, something like that. I know we've been getting some feedback where people are reaching out and they're like, hey, we like the show, and did you guys stop? And so we did not stop. So now we're doing kind of a temporary studio, but we got to remember how to do a podcast. I mean, it's been 6 weeks, possibly 8 weeks.
You know what I know? I know that Paul doesn't like it when
No. You can't smack the table. You're not supposed to do that.
Should we adjust the microphone?
You shouldn't even touch the microphone at all. So those two rules. No smacking the table, and don't play with your microphone.
He doesn't like it.
So that's podcasting 101.
Okay.
All right. So we have to remember the basics here. So
he's really excited that we're back.
Yeah. So the problem with doing it in this studio is that our producer is actually watching us and giving us foul faces and finger signs. So
yeah. I feel like I'm in a lineup.
Yeah. Well, what's going on, man? Let's get caught up. How you been?
I'm great. I mean, things are good. Kids healthy, grandkids awesome. Weather's warming up, and still playing in the bands, and it's been a good time, man.
That's right.
Yeah.
You're like really into the bands. Are you guys doing arenas yet, or
not quite doing arenas?
Yeah.
I don't think. I mean, we could do one, and it would still be a really small crowd. What about you?
Things are going well. We've got a lot of stuff going on. I've been working really hard. Spoiler, I'm working on another natural product. So
it's so good.
Been working hard on this, and that's part of the reasons why we have to carve out some time to do the podcast. Love doing the podcast. Miss you.
Yeah.
Everything else is going really good. Shout out to the University of Texas men's tennis team. They just won the SEC conference championship.
First year in the conference.
And they are the SEC champions.
Yeah.
So they're heading into the national tournament coming up here, where hopefully they can possibly be a run for a national championship.
Shout out to Lucas Brown. Yeah, that's awesome, man.
Yeah.
That's great.
So, yeah, Lucas is funny. He's getting some NIL deals, and they're requiring him to do some social media posts. So he is outsourcing that to his sister.
Yeah, I was going to say.
He's paying Carla to do it.
The one thing that Lucas loves is being on social media.
So she's his social media manager now. So I don't even remember his Instagram, but anyways, it's LBO4 something, whatever. I'll look it up real quick.
He may not remember it either.
He probably doesn't. But just in case you're a UT fan, Lucas_Brown_04.
All right. Sick. Yeah. Well, good for him. That's great.
Yeah, so super excited about that, and seeing the kids. Carla's going to be going to Gonzaga, playing tennis there. Yeah.
Soon.
Very, very happy for her that she found a university that she really likes. So if you know any friends in Spokane, share this podcast with them. Let's get some Zags on board. Listen to the podcast.
She and Dan Cummings will be two that have come through Gonzaga. So it'll be awesome.
Dan Cummings?
Yeah, the comedian.
Oh, yeah. I only remember John Stockton.
Yeah, this guy too.
Pass that ball like Stockton.
Yeah. He was okay at basketball.
Well,
what's up, man? Let's talk about something.
The topic. We're revisiting something here. GLP-1 agonists, the Ozempics, the Mounjaros, the Wegovys. We did a whole episode when they first came out.
Yep.
And we kind of attacked them a little bit.
Because
of the different side effects that we were seeing. But now there's this movement, and I'm seeing this online, I'm seeing it with wellness doctors, of considering that possibly these GLP-1 agonists are actually healthier for you if you microdose them or use a much, much lower dose. And so that's what I want to talk about today, microdosing GLPs.
Just to preface this topic, I mean, whenever we first more or less addressed the GLP-1 agonists, we discussed that they already had been in use at some level strictly for diabetics, but when they moved into the weight loss arena, they significantly raised the dosage. So it's kind of interesting that now we're moving to utilization of these GLP-1s, however, at a much smaller dose where people there wasn't a controversy, in other words, around GLP-1 agonists whenever they were only being dosed for the diabetics.
Mm-hmm.
So, and it didn't really come into the consciousness that there could be some dangers there until it started being used just kind of willy-nilly with everybody for weight loss, which was significantly higher. So this makes some sense.
It is absolutely shocking how many people are on these medications because there's so many people that they just see everybody's just dropping weight. You see it in Hollywood, all these people are losing tons of weight. And so a lot of people are using these. The reason why I wanted to talk about this is because I had a patient recently who came in and she did not look obese at all. And I noticed that she was on semaglutide. And I brought that up. I was like, oh, interesting. How are you tolerating it? I always like to ask my patients how they tolerate it. Some people have severe side effects, which we're going to get into in a second. And she said, well, it's really interesting. My doctor put me on this very low dose. And what I've noticed is that I've been able to get off of all my anxiety medications and my antidepressants. She said, I feel amazing on it from a mental standpoint. And that's actually why I'm taking it. And so that got me thinking about this whole microdosing. And as we're going to talk about this, there's not a lot of data on this at all.
Sure.
This is all anecdotal. These are just doctors that are compounding this and trying to use lower doses. But there seems to be a lot of good feedback on that. And so that's what I want to talk about.
Let's do it.
Let's do it. All right. Just to recap, glucagon-like peptide 1. When you start to look at this, it seems super confusing. Basically, every time you eat, the small bowel will actually release glucagon-like peptide 1 and GIP, which is an insulinotropic polypeptide.
Okay.
So that's GIP. Everybody uses these, but I can't even say it. Insulinotropic. And what that does is that actually increases insulin to drive sugar into the cells, decreases glucagon, which when glucagon floats around, it pulls sugar from like the liver and things like that, and it slows digestion and it promotes satiety and decreases appetite. Now, we've learned a lot about these GLP-1 since they first came out because there's been a lot of anecdotal evidence of all these other things that are going on. But we now know that these hormones have a direct dialogue between the gut and the brain. And so the way this works is that these receptors, so your small bowel releases these are naturally occurring. We can call them hormones the way they act since they go someplace else and interact, but they are peptides. The receptors are found in the pancreas, the brain, the gastrointestinal tract, and even the heart. So when it stimulates the pancreas will produce insulin. It will decrease glucagon, and this helps control blood sugar. When it actually activates in the brain, this leads to feelings of satiety and fullness and can reduce cravings and overeating. I have talked to some experts in the field, and they think that there could be other effects in the brain, like possibly affecting dopamine, possibly affecting GABA, which is why we're seeing some people that have addictive issues. Those things kind of go away, and it's possibly due to this. It also, there's some receptors, some neurons that we now know, POMC and NPY-AGRP, which are satiety promoting. And it does appear that it decreases ghrelin, which is your hunger hormone, and makes your body more sensitive to leptin, which is the thing that makes you feel full. Now, the funny thing about leptin is that leptin is primarily produced by fat cells, adipose cells. So the interesting thing is that if you become more sensitive to leptin, then the leptin being produced by the fat cells, you actually feel full quicker, or it'll tell you that you're full. Without it, the more obese you get, the more that you're actually becoming resistant to it. And as you'll produce a lot of leptin, but you have some resistance. As you lose the weight and lose the adipose, you're not producing as much, but you're more sensitive to it. So there's this cyclical thing of how it's probably controlling your appetite. Bottom line is when you have GLP-1 and GIP floating through your system, you really are controlled in your desire to eat. You feel full, and that's one of the primary mechanisms of how we feel full. This is what's going on in the body. Now, there are some preclinical studies showing that when these peptides are floating around in your body, it does appear that there can be anti-inflammatory components to it, decreasing inflammatory cytokines.
Okay.
This episode brought to you by Atrantil Pro.
Wait. Did Atrantil Pro really bring us anything?
No, Eric, you're being too damn literal. No, it's not like bringing the episode, but It is bringing proper gut health to people and a probiotic that actually works.
Okay, that's fair. Go to kbmdhealth.com and get your Atrantil Pro today.
And then there seems to be some new evidence that these receptors, the stimulation on the brain, like I was saying with the dopamine, possibly GABA, and these other things actually help with decreasing anxiety and decreasing stress. It's super emerging about what all these things are doing. The problem is, since so many people have been on these, it's filled with side effects, right? So we know that you've got nausea, vomiting, you've got constipation. A lot of my patients that are on these end up getting really bad acid reflux.
Mm-hmm.
And if the stomach isn't moving, that acid sits there, gastroparesis, and you start getting bad acid reflux. The bad things, there have been cases of severe pancreatitis. There have been cases of severe gallbladder issues like increased gallbladder stones and gallbladder infection. And thyroid cancer has also been linked to this. So scary stuff.
Yeah.
And what's really interesting is that although there's some evidence that it improves mental health, there have been a large subset of people that develop significant depression. And it could be because the reward system was eating.
Mm-hmm.
So this is a completely moving target. And this doesn't even get into the fact that all this weight loss is disproportionately also muscle loss and connective tissue. And so it's the kind of the running joke, no acetol. People that take this, they basically lose their gluteus muscles because it's a large muscle and you're consuming that disproportionately to just a diet alone.
Yeah. So a diet, I mean, just to recap, a diet alone, typically you would lose a higher percentage of body fat versus connective tissue and muscle. And if I remember correctly, the description, I don't remember what physician it was, but described that whenever you're taking a GLP-1 for weight loss, you almost lose all of these tissues at the same rate. It's a third, and a third, which can predispose you to injury, tears, and then losing muscle is not lean muscle is not what you really want to lose, because if you're gaining strength and even if you're working out and trying to supplement, how you're losing weight, you may be predisposing. Maybe I don't know.
Well, I don't know. I think Peter Attia talks about this a lot. Not so much about the GLP-1s, but about maintaining muscle mass as a longevity aspect.
So it's going to always improve your BMR. Your basal metabolic rate depends upon you having good lean muscle.
Yeah, and so maintaining your muscle is super important as you age. So I understand that when people take these as a medication, that if you're morbidly obese and have diabetes, it's pretty wonderful. When I went on Gabrielle Lyon's show, we kind of had this back and forth a little bit because she's a big fan of it, and I get why, because if you're obese and have diabetes, I'm not, because I'm seeing the gastroparesis, I'm seeing the people that can't prep for a colonoscopy, I'm seeing the GI side effects. And so my world of that is people coming in with more gut issues. But for those people that have a certain BMI, it does amazing. Cholesterol, I guess the lipid panel improves, there's decreased coronary events, decreased stroke, but so many people are taking them that we don't really know what the long-term consequence at these high doses.
Correct.
So these drugs that we're talking about, unless you've been living under a rock, the peptide semaglutide, this is where it gets really confusing, because semaglutide is a peptide and it's a GLP-1 agonist, but it comes under the name Ozempic, Rybelsus, and Wegovy. And the other one, Mounjaro and Zepbound now, is tirzepatide. And tirzepatide is a dual-action GLP-1 and glucose-dependent insulinotropic polypeptide. I don't know why I can't say that word. So it's a dual-acting thing. And that's the Mounjaro. Here's the interesting thing. There's so many more of these coming out.
Oh, sure.
Or versions.
Yeah.
So when you look about things that are being filed with the FDA, the next one that's probably going to come out that's right around the corner, and some of these, I believe you can still get like at a compounded pharmacy.
Yeah.
Because it is just a peptide.
So and for a compounding pharmacy to be able to do that, it just has to be less than 50 chain amino acids, and I think they can do that. That's the threshold.
Yeah. I think so, yeah. I think you're right. The one that everybody's really excited about is retatrutide. And this will be a triple agonist targeting GLP-1, GIP, and glucagon receptors. So a lot of people feel like this is being developed by Eli Lilly and it's in phase 3 trials, but there are people that I have seen that you can actually get this as a peptide. And then there's like another one called CagriSema. It's a combination of cagrilinotide, an amylin analog, and semaglutide. There's another one called orforglipron. And this one is going to be an oral, non-peptide GLP-1 receptor agonist.
Can't wait till that commercial.
I know. So that one's going to be the first one to be oral. And then you've got another one called amycretin coming out. And then you got another one called danglipron. And I talked to one of the PhDs that she was at a weight loss summit, and there's like 5 more coming out. And she said there's so many drugs coming out having a combination of one of these peptides with something else.
Sure.
So like if a drug company owns something, they say, oh, we can come out with a new drug by adding the peptide. And they're filing. There's just so many weight loss things.
I know that the bleeding edge on Netflix was more about implants and devices that people use in medical care and getting things grandfathered in. But this is exemplary of things being grandfathered into the FDA. It's a quick route to get a lot of these things passed. Once one of them has broken through the barrier, they kind of get to piggyback, and it really kind of shortchanges the exposure for safety profiles being performed and different tests like that for them to look at it. So some of these may sound great because they've got multiple action points. We don't know that. We don't know if that's good or bad. So
yeah, I don't think people realize how much connective tissue muscle mass they would lose. I don't think anybody realized, because all the studies done on diabetics, they didn't realize that there would be this portion of people that get pancreatitis, this portion of people that can end up with these other issues like we talked about.
Maybe we can clarify this though, but at the diabetic dosage, which is less than the weight loss dosage, there weren't, if I remember when we did the episode, there weren't near as many collective numbers of side effects by percentage or in total for people who are on the lower diabetic dosage versus the weight loss dosage.
If I recall, and I think that's where some of these doctors are going, well, wait a minute, what if we go lower than what they did for the FDA approval of diabetes? Hence, the new microdosing thing.
Yeah.
Which I will say, because when you Google it, it's going to say all over, this is not FDA approved, we don't recommend it. To do it is real difficult, but screw it, because people are doing it, and I was kind of impressed that patients are taking the health, they're taking it into their own hands. And they're going to their doctors, and if these doctors are trying it out, anecdotally, let's see what's going on.
A large percentage of the use of medications nowadays, already before this is even introduced, are already used, quote unquote, off label. It's not nearly as damning as it sounds whenever you see it on Google. It just simply means that a physician or nurse practitioner or someone has found a safe use of a product that's not exactly written exactly like that on the label. So,
but we got to wait for our wonderful parents, the FDA, the American Heart Association, and these societies to approve and disapprove. Did you see that thing where the American Heart Association was like recommending that very sugary sweets like Coca-Cola be allowed on basically subsidized stamps and things?
They have your best interest at heart, all of them.
You can't blame them. I mean, if an industry like Coke is going to give the American Heart Association however many millions of dollars, no, they're not influenced at all. Totally separate discussion.
I'm sure it's altruistic for sure.
Very altruistic. All right. So now let's compare these dosages.
Okay.
Like what is microdosing versus whatever. So typical dosing, and they're slightly different between these different GLP-1 agonists like semaglutide or tirzepatide, but basically most of the time the recommendation is to start at 0.25 milligrams once a week, and then increase slowly over time to 0.5 milligrams, then to 1, then to 2. And what's interesting is if people can tolerate it and get all their way up there, they really do have this rapid weight loss, right? And a lot of patients that are on these medications, especially at this dose where it's maintaining the weight, they want to continue to maintain that. But I've talked to doctors that say, no, the hard thing is when I try and tell my patient, you've lost enough weight, let's back off, the fear of gaining it back and all that has become an issue. And then, of course, cost is an issue.
Sure.
Because if you're doing 2 milligrams a week, and the drug is extremely expensive. If it's compounded, maybe you get a little bit cheaper. But if it's the branded one and your insurance doesn't cover it, I mean, it is extremely expensive. $1,500 a month is what I've heard.
Oh my gosh, yeah.
Yeah. So, microdosing. What does this actually mean? And It just means using a much smaller dose. If you have SIBO, it sucks. If you don't know what SIBO is, then quit listening. But if you do have SIBO, it does suck. And we have something for you. It's called the SIBO Support Box.
SIBO Support Box. You don't even have to worry about carrying around a pill case. We have everything measured out morning and night.
So this is going to cover multiple aspects that help people with SIBO. Go to kbmdhealth.com to learn more. People are kind of moving this around, but the people that have discussed microdosing, they start at 0.05. So
significantly lower.
Significantly lower. 0.05 up to 0.1. And some have gone as far as calling microdosing 0.25, which is the starting dose of the actual medications.
Okay.
So you don't go above 0.25, but if you can get some of these results at 0.05 or 1, are you going to start having these side effects? Well, it looks like that you do end up with much fewer side effects to begin with. Makes sense.
Sure. Well, you're practically topping out at 1/10 of the top end dose of the traditional weight loss.
Yeah. So all these people that have tried these medications and ended up with severe nausea, severe acid reflux, severe constipation, maybe it was just way too high of a dose.
Yeah.
And you're not able to actually achieve some of these things. And so it is possible that you have improved tolerability and you can have extended benefits, because what's being talked about is you have doctors writing that when they put people on these microdosing, that they have seen improvement in mood, like I talked about my patient. They've seen improvement in autoimmune issues. So you've got rheumatologists now that are recommending this to treat autoimmune stuff. Off-label, not recommending it, but I admire when doctors start thinking outside the box. You go, well, if it lowers the cytokine profile, and when you can start losing a little bit of weight due to what we talked about, the satiety control, you're not having this rapid weight loss. And so what people have not been able to explain to me is, why do these medications create so much connective tissue loss, muscle loss, including fat loss? There's something else going on.
I agree.
There's more, because these are hormones. They affect different things. We don't quite understand it fully yet. So the microdosing, obviously the research is super limited, but what ends up happening is that people may have weight loss over a much slower period of time. But what if it could be beneficial in autoimmune? What if it could be beneficial in mood and in addictive personality type things, where if you're a stress eater, things like that, maybe the little tiny dose without these side effects is the way to go.
Who knows? And they may even discover that even lower than the recommended 0.05 is a good place to start for some. I have no idea. I will say it's kind of interesting that the way that people in the medical community and people who are all too ready just to try anything, when it comes to hormones, it seems like that people are, when something's new, they'll just go and they'll just do it. And take testosterone, for instance. If somebody were to naturally improve their testosterone, they could improve their diet. They could make certain that they lift heavy weights. They could make certain that they're getting good sleep. But if someone decided that they wanted to improve their testosterone and they did that for one day, will the next day their testosterone level just be off the charts? No. It takes time, right? The body's going to mold itself. It's going to adjust. It's going to begin to create more testosterone over time to meet the demands of the body and then to keep on the muscle and the muscle distribution, et cetera. Well, it's kind of interesting that they've already discovered a little over a year or 2 years after, big, massive use of these drugs for weight loss, they can actually start to get people to enter at a dosage that's about 1/5 of the original initiation, and they're getting better tampered results because your body's not meant to withstand a hormone surge. And a one-pill-fits-all mentality is that, I think, oftentimes is what leads to absolute no control and then the discovery of a litany of other side effects, even if it happens to be thyroid cancer or whatever. You don't know it because your body wasn't ever built for that. But you're drinking from a fire hose when really you just needed a sip of water. So it's kind of interesting. Anyway.
Yeah, it really is, because maybe the drug companies overshot the dose too much, but look what it did.
Well, it sells more
Everybody-
product.
It sells way more product.
That's the thing that it just honestly just pisses me off, because had you taken a little bit more time to evaluate these different dosage ranges, maybe we don't have people who now have stomachs that won't empty, and maybe we don't have people now who have unnecessary thyroid cancer, or they're just throwing up for no reason. I mean, that stuff sucks. Nobody wants to live like that.
I mean, there's so many different ways that you bring up testosterone. One of the complaints I have is when people go to like one of these like men's tea clinics and they just get this whopping dose of testosterone and say, come back in 2 weeks. So this huge spike and then they crash. And then that's a surefire way to bring your patient coming back in, as opposed to doing it just a little bit and keeping the physiologic hormonal level that's there.
You can run that experiment on a young child. They're a little, not tuning in to what you want them to do, so you kind of win them over by giving them some sugar. They love you. 40 minutes later, they need more, and you don't have any more. An hour later, they don't like you at all. They're crashing, or they're tired, or they've fallen asleep. It's the same thing with the tea clinic. I totally agree. You're loading them up, and it's creating a perpetual customer.
Yeah. My current physician assistant, who's been with me for the last 10 years, I say current, she came from a clinic where they did that. And she's like, these guys would come in and they're desperate. If they couldn't get their shot because they feel horrible.
Oh, worn out, bad mood. They don't want to do anything. Yeah.
Yeah. And it's just, and they know as soon as they get it, it's like, I just talked to the CR now I was working with yesterday. She was feeling a little sick. And so she was working like a plastics clinic. And she's like, man, I need a little shot. She got a shot of, what steroid is it? Depomedrol?
Oh, okay. Isn't that the birth control?
No, not Depomedrol. Anyways, a really strong steroid.
Oh, okay.
And she did not realize how strong it was. She stayed up for 2 full days, like cooking, cleaning. It's the one that they use. It also
Decadron.
Okay, that's it.
Okay, good.
Decadron. Okay. Depo. What did I say?
I think what you said is
I said a birth control.
Yeah.
Decadron, because I've never used that steroid. I do know that like orthopedists will use it in joints and stuff at low doses, but she took a big whopping dose and she had this tremendous like mania.
Yeah, can't sleep
days.
probably.
Couldn't sleep 2 full days.
Yeah.
She said she was just reading like crazy.
Blood sugar's probably off the charts.
Everything. Yeah. And so.
I speaking of that though, there are other things that happen like that. I've got a friend of mine, and I wouldn't call him a friend, it's just somebody that I know, but they've got people that come back and just want more and more and more. But he has been
come back more of what?
Of his product. He's been selling crack for a long time.
Oh, yeah.
And just enough, and they feel good. And when you know, they come right back. Paul knows him. I know him because of Paul.
Yeah, yeah. But that's FDA approved crack, isn't it?
I don't think so.
Oh, okay. Yeah. Well, everybody's got to pay the bills. So, microdosing, let's look at some of the benefits.
Okay, let's go.
All right. So there's reduced side effects, just like we're getting into. You can have less nausea, vomiting, and GI discomfort, and smoother autoimmune response. So why aren't we hearing all about this huge autoimmune response with the standard dosing? Could be that the smaller dosing actually has a much better response to allow the body to accommodate to these inflammatory cytokines. So smoother. So we're talking about autoimmune conditions like psoriasis, rheumatoid arthritis, inflammatory bowel disease. There's anecdotal evidence that these people get put on this and they feel better. Very interesting. It's not proven yet, but what we're talking about is patients coming to me and saying, no, definitely, this has helped at this dose with my mood or my autoimmune. Other doctors have talked about it. I've been to some lectures where functional medicine doctors are using this like this for autoimmune things. Decreased anxiety and mood regulation. I don't know, what is your hypothesis? Some are saying, it's because you're controlling the blood sugar better. You don't have the highs and lows like you're talking about giving sugar to a kid. Yeah. Maybe that has a component, or maybe there is other receptors that are being targeted in the brain. All I know is that this patient was able to get off 3 antidepressant, anxiolytic type meds, and all she's doing is microdosing the GLP-1 agonist.
Any element of improving your diet is already going to recondition the way that you have a reward system in your brain anyway. So maybe this kind of helps people avoid the triggers that draw them into going and getting a candy bar or some kind of trash food. And so once you just begin to condition yourself, it's like somebody who's already healthy. Let's just take the weight loss out, but somebody who learns how to become ketogenic. You and I've experimented with that in the past, and still do, kind of just de facto. But somebody at first, when they're trying to enter ketosis and get in that, it's kind of funky. You're not really sure how you
the
feel.
keto flu, people go through.
Some people get that. I never got that.
Yeah.
I don't know. Did you ever get that?
Mm-mm.
But some people do. They talk a lot about it. But going through that transition, your body literally is changing its fuel source. So you feel kind of different doing the change. But once you get in that groove, well, now you feel good. When you have your healthy fats, the satiety is easily reached, and it's really easy to avoid foods that used to kind of pull you in. So I kind of wonder if the reward system just gets rewired or reoriented in somebody, and now they've just kind of got like a regulator helping them along the way.
But then also, this is more of a stable, metabolic, slow fat loss decline.
Yeah, sure.
It is
isn't
much more
that the way you're
natural.
supposed to do it?
Yeah, it's definitely the way you're supposed to do it. And then you brought it up, but one of the reasons why people are microdosing may not have ever actually been because of, there could be some evidence that microdosing is better, possibly it's less side effects, but a lot of people started doing it because they couldn't afford it.
Yeah.
And then by doing a much lower dose, make it last longer.
If you're doing a 10th of the dose, you went from your, what'd you say, 1,500 technically down to 150 a month?
Yeah.
It's a little more reasonable, I guess.
I mean, I think
it's $5 a day.
Yeah. This is, I could totally see how this is at least an option. And of course, every time you look it up, it's, remember, this has not been studied. I mean, screw off. It's being studied right now. So many people are doing it on their own. Mm-hmm. They're even trying to do a lot of people are getting from compound pharmacies, but they're trying to do little micro clicks. Like it starts at 0.25 and maybe you can do just a little bit less. The autoimmune stuff, I'm pretty excited about this just because there is evidence to show that it decreases interleukin-1 beta, TNF alpha, and this is in animal models.
Yeah.
But if that is true, then this could be augmenting treatment for autoimmune issues. And maybe we need less of these biologics and things like that, or these, steroids that can actually create all these other side effects.
Well, chronic inflammation is going to lead to more cortisol production. It's going to lead to more weight gain regardless. So it seems to kind of go hand in hand. If you can control an autoimmune situation for most, you would be able to, you'd have better luck at controlling weight and everything else.
Yeah, I kind of wonder also about this whole brain-gut access with this microdosing the GLPs. Because is there a component where through the vagus nerve, something is happening because GLP-1 is being released by the small intestine? Mm-hmm. Could there be something going on with the vagus nerve that's actually decreasing neuroinflammation? Because they don't really understand the whole mood thing. Is it strictly related to blood sugar stability? Is it related to possibly a dopaminergic pathway? Is it related to these other weird pathways, the POMC and the NPY, AGRP? Aren't
we also inhibited from producing high-quality serotonin whenever we are chronically inflamed?
Well, we do know that, since serotonin's produced in the gut, if your gut is inflamed, for sure.
What I'm saying, serotonin production in your brain as well as serotonin production in your gut. I mean, we talked about how the tryptophan can be halted a little bit. I can't remember what enzyme it is, but the conversion over
tryptophan hydroxylase.
Yeah, thank you. It gets inhibited by some of the inflammation and its rate of production of serotonin.
Yeah.
So I'm just guessing because I don't know.
Yeah. So what if one of the reasons why is because since it works in autoimmune disease, what if it's decreasing inflammatory cytokines that allow your body to produce more of its natural happy hormones that are actually floating around?
Yeah.
I don't know. There's a question to be asked, but
sure.
It is very interesting. That whole gut-brain axis, the gut-brain immune system that we always talk about whenever we talk about gut health, this is kind of playing into that. I think that it is playing a role in that triangle.
I agree with that.
Yeah. So my view is I think that this is going to possibly be the future. Now, what really is the future? Is it all these other medications that are coming out? I don't know. But what you can do is, since this is a peptide, and if you're getting a compounded peptide already, then you can talk to your doctor about, can you do other peptide stacks to help decrease more inflammation? Like, for instance, if you're going to be on a GLP-1 agonist, I know a lot of docs say, then I'm going to put you on some sort of growth peptide to maintain your muscle mass.
Oh, yeah. McKenna talks about that.
McKenna talks about it. He says that I'm going to put people on GLP-1, but they're going to take ipamorelin CJC.
Actually, and he was way ahead of the curve. He was talking like that a year and a half ago.
He really was, yeah. I wonder if he's doing microdosing. or if he's using it.
I'm sure he is.
Yeah.
I haven't asked him, but yeah, I will.
Yeah. We did. What he's talking about is Dr. Wade McKenna, stem cell expert, came on the show. And yeah, he's always been ahead of the curve with that. And so, yeah, he's saying, so if you're going to take this and you want to maintain your muscle mass, you take your semaglutide plus tesamorelin or ipamorelin or sermorelin, CJC. There's so many of them out there. This whole world of peptides is so fascinating.
Yeah.
And the fact that the FDA keeps trying to get involved and ban them, and then like the ones that actually work, I know that BPC 157 plus TB 500 work as an anti-inflammatory combo.
Yeah. And recovery too, right?
Yeah, and recovery. And these have been around. It's really funny because these peptides have been certainly in Eastern Europe. Mm-hmm. That's where all the studies come from, like Russia and places like that. I know Russia's not Europe, but over there.
Yeah, part of it is.
Yeah, little part. Yeah. They a lot of bodybuilders have been into this stuff for a really long time. So they're very aware of these peptides. This is not like novel new things. These things have been around for forever. We were talking with Paul about melanotan.
He's a big fan of melanotan.
Huge fan of melanotan.
Uses it every day.
And so, but like he said family members have been on it 20 years ago. Mm-hmm. People have been using these things for a long time. So this GLP-1 thing, it's just a peptide.
Yeah.
These peptides have been studied like crazy.
They have. I think whenever they become commercial is whenever, unfortunately, it's kind of when things become dangerous. And so I wasn't a big fan of any of these for just the previous weight loss dosage. It just didn't seem right. Didn't seem like enough research. So I'm interested to see long-term what comes of it. I mean, with any of these things, I'm still kind of cautious, especially those that have more than one mechanism of action and they don't fully understand it. The combo ones, you have to approach them with caution. We don't know. Yeah,
and we still don't know all these people that were on it for a long period of time and then they have to stop abruptly. We are seeing people gain significant weight back fairly quickly.
Sure.
And it's not good weight. It's usually more adipose to muscle because it takes so long to replace the muscle. Yeah, that's another whole thing. But so this is kind of fascinating. So if you are somebody who's taken a GLP-1 agonist, semaglutide or tirzepatide, and then these other ones that are coming out, either if you had side effects or it costs too much, maybe you should talk to your doctor about possibly doing some microdosing. After doing a little bit of reading, it's very little data out there. Mm-hmm. So I'm at least entertaining the fact that maybe if I'm ever going to prescribe these, which I haven't yet, I send them to other doctors that do it all the time. Mm-hmm. But if I'm going to start prescribing these, then I think I'm definitely going to try and go with this microdosing model.
I mean, it can't. It's like in anesthesia. Like if someone is in mild pain or a little bit of anxiety, but you don't want to overdose them, you start off with a little because you can always give more. You can always give more, but once you give it, you can't take it back.
Yeah, I think the problem with these medications is that they see their neighbor who's dropped 70 pounds. Yeah. They start on it and they're not dropping weight. So they run back to the doctor and say, I need more. Yeah. I want to drop this weight like now.
I mean, you just kind of get to a fork in the road though. I mean, are you losing weight just purely for the vanity or are you losing weight to get healthy or where are you? If you're only losing anything just for vanity, eventually the pain and the price more than likely will not be worth the exchange. But that's just me. That's what I think. So if you're going to do it, just proceed with caution and think about your long-term future or at least your family members that like you.
Yeah, and we don't know anything. Will there still be a component of pancreatitis? Will there still be a component of thyroid cancer? Can there be gallbladder issues? Well, we don't know that yet.
I think the rates will be lower just simply because of what's happened between diabetic dosing and weight loss dosing. However, by what degree, I don't know. But it's worth finding out.
Yeah, so that's our comeback to GLP-1 Part 2.
Yeah.
We've had, I don't know, when did we do that first episode? Because it's been a long time because it was when they first came out.
It was in the other studio, Ken.
Everything was in the other studio.
Oh, that's right. All right. Well, that's going to do it for this episode.
If somebody has a room that we can rent out in their home and build the studio there.
Or a van.
Or a van.
Yeah, we can do that.
If you got a van down by the river, let us know.
We have a mobile sign. We could do something. We'll see y'all next time.